Hello, one and all. Warm welcome to one and all. We have already warm welcome to Dr. Biju Raghavan too. Hope you can hear me. Right?
Yes, sir. Yes, ma'am. You're audible.
Okay. And as I said, warm welcome to Dr. Biju Raghavan. We have already had an interesting interactive session which each one enjoyed. So we are going to have another one session. So we are all eagerly waiting for it. Dr. Biju Raghavan is the consultant and HOD for pain and palliative medicine at Rajgiri Hospital, Ernakulam, Aluva. And he's also visiting faculty in many other centers in Trivandrum, Hyderabad, and so on. And he has been practicing palliative care for a long time, which is the most best benefit to us to get something to be taught by someone who is a pioneer in it. And his main interests are oncology and respiratory palliative care and end of life care. Over to you, Dr. Biju Raghavan.
Thank you, madam, again for the kind introduction. So good to see you and so good to see everybody else on the screen. Good to be back here. Thank you, Palim India, for keeping the invitation open for me. So I'll start today's session by first sharing the screen. Right. So today we are going on to the second part of the communication skills program, which I call advanced communication procedures. Why the word procedure? Because we have to see communication like a procedure. Whatever we do, there is an indication for doing that. There is a standard operating procedure, a methodology of doing it, and at the end, there is an expected outcome. It happens or not, it is different matter, but we expect a certain kind of outcome. And that is why it is called procedure. So what are we going to learn today? Primarily three things: communicating bad news. Initially, we'll be talking about the different models that we have and why we should communicate bad news. Then we will take a detour. We will go to totally different topic. It's called collusion and how to manage it. Then we'll come back again to communicating bad news, this time on how to do it. Because you can communicate bad news only if you have the green signal from the family. For that, you have to manage the collusion. And so that is why I have purposefully put in collusion in the middle of communicating bad news. And once we're done with it, in the end, we will talk a little bit about managing anger in our clinical environment. So telling truth is never easy. It is very difficult. And that is why communicating bad news is such a hard thing to do, because it involves telling the truth. And there are primarily two ways that we see how we do it. In India and most Asian cultures, we do not disclose the bad news. We do not tell the truth to the patient. And the very, very common scenario in our context is the patient and family walks into the doctor's room, and the doctor has information to discuss, but the doctor would tell the patient to go out. And the patient meekly gets up and leaves and waits outside the room while the doctor is conveying the truth to the family members. Now, the patient waiting outside knows fully well that they are talking about me, but they will not talk to me. I don't know how many of you would want to be in the shoes of that patient. How many of you would want to be that patient? who knows that there is something going on. Probably it's not a good news, and definitely they are trying to keep me out of it. But that is the model we practice here. We do not disclose to the patient. That is why we call it a non-disclosure model. Of course, we disclose to the family, but we are not disclosing to the patient. Therefore, non-disclosure model. We may have our own reasons for not doing so. Some of the reasons are there in the dialog box over there. However, if you are, if you were that patient, would this be acceptable to you? Maybe not. Therefore, we have to understand that this can get into conflict with what the patient wants. If the patient wants to know, then this model of non-disclosure model gets into conflict with the patient's right to know. And the right to know is very much part of the first principle of medical ethics, which is autonomy. My life, my body, I decide, I want to know. So it is all under the first principle of medical ethics, which is autonomy. The patient may want to know it for various reasons. But if the patient wants to know, the patient has the right to know, and practicing non-disclosure model gets us into conflict with the patient. In some parts of the world, the doctor is by law sometimes mandated to tell the truth, nothing but the truth and the whole truth to the patient. And you can talk to the family only with the permission of the patient. If you don't do that, you can be sued. You can be taken to the court, and the court will say that you did wrong. You will be penalized for it. So in those countries or in those cultures, whether mandated by law or not, the truth is told to the patient. And that model is called the full disclosure model. Telling the family comes later or along with the patient, but the patient is told the truth. And what if a patient does not want to know, or at least presently is not prepared to know? There also, we can get into conflict with the patient's right not to know. See, it's a right of the patient. The patient does not have the duty to know. Autonomy means my body, my life, I decide whether I want to know or not. The patient may not want to know for various reasons. So the two prevalent models of truth telling is either non-disclosure model or a full disclosure model. Both can get into conflict with the patient depending on what does the patient want, because the patient is an individual. Therefore, we have to design a new model which caters to the individual patient, which caters to the patient sitting in front of you. And that would be called an individualized disclosure model. Basically, what does that mean? It means you have to first find out whether the person sitting in front of you wants to know or not. And then you proceed only with the person who wants to know, not with the person who does not want to know. And while you're proceeding with a person who wants to know, you have to figure out how much the person wants to know. Because you have the full knowledge, that person may not want the full knowledge, may not want 100%, may want 60%, may want 72.5%, may want 89.8%. We don't know. So you give only as much as the patient wants, not less, because that will be unsatisfactory, not more, because it may become psychologically traumatic. You may have an emotional trauma injury. Therefore, we have to figure out two things in the individualized disclosure model, whether they want to know or not, and secondly, if they want to know, how much. The skill is in finding this. But before we proceed on to that, let us talk about why should we even tell the truth to the patient. So why is it important to communicate bad news? If I were told that I am not going to live for more than 48 hours, I will stop this class straight away, stop seeing the patients. I have a few patients to see yet, but I will stop all of that because I have very more important things to do. I have things to finish before I die. Now, very few people die a sudden death. For example, involved in a car accident or a MI, sudden death. Less than 10% of the population die a sudden death. Most of us will die slowly, and most of us will have a chance if somebody were to tell us that we have an incurable, progressive, advanced medical condition, your time is limited. Then, after the initial shock and all the crying and sobbing and just beating, once with time we come to our senses, I will think, what are the things I need to do? I will think of my family. I'll think of what are the things I need to do before I go. So it may be things related to finance, writing a will. It can be a lot of those kind of things, bank accounts and things like that. It can also be things that is personal to me. Spending time with my family, spending time with those I love, doing things that I have always wanted to do but never found time because I thought I will do it some other time. I will go on that vacation some other time. So we keep postponing things, thinking that we are going to live forever. Right now, me, you, everybody over there, we are dying right. Every breath we take, we're reducing one quota allotted to us in the beginning. So we are all technically we know it, but in real sense, our mortality comes and stares us when somebody tells us that you have limited time. It is also an occasion to mend relationship, strengthen relationship. It is also an occasion to ask for forgiveness with whom we may have behaved not so good. It is also a time to forgive somebody with whom you may have had a grudge. So it is, you get a chance to finish a lot of things. Your life's business can be sorted out before your body and mind gives up. And the earlier we communicate bad news, the more time we get to finish everything that we need, or at least as much as we can. The second point is about hospital hopping and doctor shopping. If you have not told me what my reality is, I don't know, but my expectation is I will get back to my normal life. For you, it is unrealistic. It is way above what my reality is. But I don't know that. So I can't be blamed if I don't find your treatment satisfactory because you are not reaching to the point where I want to be. I want to be normal. I want to live my normal life. I want to get back to work. I want to enjoy life. I just want to be normal. But I don't know my medical condition cannot allow me to be normal. It just not because I have got an incurable, progressive, advanced medical condition, but it's only going to take me down. But I don't know. Nobody told me. Initially, I will grumble that this hospital is not good, surveys are not good. Then I'll say this doctor is not good. They don't know anything, and then I'll ask my family, "You take me some other place." My family knows, but I don't know. And because I insist you take me to some other place, the family, even though they know everything, they take me to another place. I go to the next place, my hopes are high. I am going to get better at this. That previous place was hopeless. This new place is great. After some days, my hopes crash again. I blame the new hospital, the new doctors, they don't know anything. They're just after my money. I ask my family to take me to another hospital, and they take me to another hospital. So I just go from hopping from one hospital, looking, going to one doctor, basically going around looking for a cure that doesn't exist. Only if I knew, I would have spent the time at home in comfort, trying to spend the remaining best part of my life with my family and those I care about. But instead of that, I'm just going around. And who is to blame for that? Think about it. And not only I'm suffering physically, I'm suffering financially, because to take me from one place to other and to be with me, my whole family is engaged with this endeavor. They can't go to work, they can't earn. And when you're away from the family, even a bottle of water costs money. A sip of water costs money. So there is only expenditure, there is no income. So soon my family will sell off the cow, they will sell off the jewelry, they will, they will borrow money, and then finally my house will be sold, and I will eventually die, and my family will be on the road, totally financially decimated, socially decimated. Who is to blame? It is our job to convey. A lot of medically induced poverty is avoidable only if we were to tell people the truth on time. The third reason I want to bring in is the barriers in relationships that happen. I often see family members who come to my OP, who sit right in front of me, and they break down and cry because the patient is not there. They came as proxy to inform, and because the patient is not there, they feel that, they feel free to express their emotion because they can't cry at home, because at home the patient is there, me, and in front of me my family members will, put on a mask of normality and play a drama, is everything is okay, right? And when they can't bear it, they will run off to another room and they'll cry, and then they wash their face and then again come back, and in front of me they will pretend that everything is okay. Or they will cry, go to the neighbor's house and cry there. They will go to the doctor's room and cry. They will go and cry everywhere except in front of, because they can't, because I don't know what is going on. So this fact, the truth has been hidden from me, so they have to act. And my body is telling me that things are very bad. I know my body does not like to. I know I am not getting better. I know I'm getting worse. I know things are very bad. Then I see all these relatives from far off places coming over to my house, and look, they come and stand at my door, and with this, the hand on the chin look, with lot of sympathy. And I hate them. I shout at my family members, why are you letting these idiots into my house? Tell them to go away. I don't want to see them. My family looks at me helplessly. They can't say anything. I hear whispers in the next room. I know they're talking about me, but I also know that they will not talk to me. Just like the doctor, you shout me out of the room and talk to my family. I know you are talking about me. Similarly, my family and relatives and other people, they are talking about me, but they will not talk to me. Like as if I have been put in a prison with transparent walls. Anybody can walk in and out, but I am in a prison, isolated, alone, all alone. What was my crime? What did I do to deserve this? That I got a bad illness? And when I die, you will put a garland around my picture, and then you will cry, and you would wish only if you had some more time with this person. What were you doing when I was alive? You're playing a drama. So this tragedy happens, almost in every household where there's a terminally ill patient. Terminally ill does not mean actively dying. That is the physiological changes of dying. That need not be there. The moment a disease is deemed to be no disease focused intervention is feasible. There is no evidence base to continue. There is no medical evidence to continue the disease focused intervention. That means the person is terminally ill. You can be terminally ill for weeks or months or even more. So it's not that you don't have time. Only thing is, we as medical professionals need to utilize this time to communicate bad news to the patient so that this tragedy does not happen to our patients. Now, we are not to be blamed alone. The family members almost often, it is an exception that a family member does not come to collude with us. The general rule is the family members will come to us and say, doctor, please don't tell the patient. You talk to us, but don't tell. This whole system of keeping the patient away never goes away. The doctor does it, the family does it. And the family is basically asking us to enter into a conspiracy of silence so that only we two talk, the family and we doctors talk to each other. We do not talk to the patient. We keep the patient away. Now, family does not have a malintent on this. Family actually is trying to protect their loved one from harm, from a perceived harm. They believe, people have beliefs. People have believed that if you take radiation, you die. Right? So people have beliefs. From medical point of view, it may seem like utter nonsense, but for people, their beliefs are real. And people believe that if you tell the truth to the patient, it will harm the patient. And if you were to challenge their belief, tell them, no, it is just nothing. It is important to tell the patient the truth. It is their right. It is our ethical duty. And if you in any way do something like that, their worst fears are coming true because they came to you with so much of anxiety, so much of fear that the doctor may accidentally or intentionally may tell the truth to the patient, and they came to you begging to you not to tell the truth. And if you are challenging their belief, if you are saying no, the patient should be told, then you're only going to increase their fear and anxiety. They may just take the patient away and go. They don't want your services because they are so scared that you may tell the truth to them. So remember, in palliative care, we always talk about the patient and family. So right now, forget about the patient, focus on the family, because now the family suffering is something that we need to palliate on a priority. I repeat, in collusion management, the family's suffering is something that we need to palliate on a priority. So basically, what should we do? When a family member comes to us and says, please don't tell this to the patient, you agree to collude. You say, okay, no problem. I will not tell the patient. I usually ask, what have you told the patient? The family may say, we just told it's an ulcer and things like that. So I say, okay, then I will also say it's an ulcer. Is that okay with you? The families, anxiety comes down, fear comes down. Right? So now their brain will start functioning. That doesn't mean they have started trusting you. That just means that their anxiety has come down. They are now a little bit more comfortable. They don't trust you, but they are comfortable and they are willing to give you a chance with their loved one. Then it is our duty to earn the trust. So I'm just talking about the standard operating procedure of how to manage collusion. The first thing is agree to collude. The second point is earn the family's trust. And how do you do it? Our previous session, active listening skills, all the body language, non-verbal and verbal skills that we learned last time, we use it. We use it to build up a relationship. Another very important method of building the families or earning the family's trust is to relieve the patient's suffering. Just imagine, God forbid, if somebody very close to you is suffering in severe pain, really distressed, and you're feeling very helpless, you don't know what to do. And in comes a doctor who comes and takes over the situation and takes command of the situation. Says, okay, we'll make sure that you don't suffer. We'll start on something. Immediately you'll start feeling a little better, and within 2 days and all, your pain will be totally under control. And once that happens, the family, you will be so grateful to this person. You would, you would trust this person who has brought a smile on the face of your loved one. So learning all the symptomatology that you are learning as part of this course properly and implementing it is very, very important to earn the trust of your patient and family. So once you have the family's trust, now they will start listening to you. That is the point where you should start reorienting the family by bringing in the topics that we talked about just a little while ago as to why it is important to communicate bad news. For example, if I just say the patient is now comfortable and the patient, let's say, has asked, my pain is okay, but I'm still feeling very tired. So I say, okay, we'll do something about it. Then I take the family away for a small discussion and I tell the family, see, now the pain is okay, but he's feeling weak, and we know the disease is progressing, and as a result his physical condition is down. The weakness part, the tiredness part, is not possible. So what will we do? So basically, I have not said what will you do. I have not said what will I do. I have said what will we do. I've just thrown this question up in the air for both the family and me, who are now a team in partnership trying to solve this problem. And thereby, this was just an example. Slowly, slowly, I'll make the family come to a conclusion that there are no easy solutions to it, and the only way to get the patient's expectation and reality mismatch to be taken care of. The patient's expectation is here, patient's reality is here. If we are to bring it down for ultimately for all the important things that we talked about, especially the three important points here, for that we will have to finally tell the truth to the patient. Now this is not easy, but it will happen. But without the family's green signal of going ahead to tell the truth to the patient, we cannot proceed. Many times the family members will ask me, doctor, I can't speak to him. Can you please talk to him? So I said, okay, fine, no problem. So I, offer my expertise on this matter, and I said, okay, fine, I'll talk to him. I also tell them that in case he or she does not want to talk about it, I will not force it. I will not force the truth on that person. I will tell only if he or she wants to know it. Now, it is possible that despite your best efforts, the family may not agree. Despite your best efforts, if the family do not agree, leave it. Be prepared for failures. If you push it beyond a point, the family will start pushing back. They will, the relationship between you and the family will go bad. And we just cannot afford to have a friction with the family of, especially of a very sick patient, not to speak of a terminally ill patient. So, as I always say, be prepared for failures. There is no shame. There is absolutely no shame in failing. The only shame is in not trying. If you tried, you have done your karma, maybe it will happen, maybe it will not happen. But at least try. And those of you who are in the just beginning on this journey of communication skills and doing this kind of things, your failure rates will be more. So don't feel disheartened. It is just like any procedure. When we learn something new, we don't become an expert overnight. We continue, we have lot of failures, we continue, polish our skills. Eventually, our conversion rates improve. But it is never going to be 100%. The best of the best communicators cannot have 100% strike rate when it comes to collusion. There'll be always family members who will resist this idea of telling the truth to the patient. But try. For every patient, for the sake of patient, try collusion management with the patient's family. Once you have got the green signal from the family, now you can go to the patient and communicate bad news. The most common SOP everywhere that is used is the spikes protocol. Basically, it's a mnemonic setup which is setting up for the interview, creating the environment, ambience, and assessing the patient's perception. What does the patient know? Remember, in our previous session, we had talked about history taking 2.0. In it, there was one part which was about trying to find out the patient's insight. Perception, insight, the same thing. Basically, we want to know what does the patient knows. Now, this has to be looked into in the first part itself. That is when we are seeing the patient and we are taking the history. That time itself, we should dig for more information and try to find out what does the patient know about his or her medical condition. What is going on, in short. Then I is for getting an invitation from the patient to communicate bad news. The patient may agree, may not agree. The patient may give the invitation, may not give the invitation. So you proceed only with those patients who give this invitation for sharing the truth. And once you have this invitation, you share the truth in a language, in a simple way that the patient can understand. And well, be prepared for emotions to flow, and we should learn how to deal with that. And once we have taken care of the emotion, then we can discuss about what can be done, what cannot be done, when are we going to start, when are we going, where are we going to do, etc., etc. The strategy and then the summarizing of it. That is essentially what the spikes protocol is all about. So let us learn how we are going to do it. Here I have a cooked up fictional 100% fictional medical story of a patient called Mr. Bharat. And this is a reference letter that Mr. Bharat has brought to you. And what does this reference letter inform you? That Mr. Bharat is a 60-year-old gentleman. And 2 months ago, he had an abdominal discomfort and weight loss. And initially, he went to the local GP, and the local GP referred him to the gastroenterologist at the city hospital, where a CT abdomen showed a mass lesion stomach, and endoscopic biopsy showed histopathology of the CS stomach. Exploratory lab was done, which showed multiple peritoneal mets. So nothing could be done. They just closed up the abdomen, and then this patient has been referred to you for quote unquote symptomatic care or supportive care, because most doctors just don't like to use the word palliative care, so they write other words. And so with this reference letter, the patient is sitting in front of you, and even though you have got all the information, but you need to start building a relationship with this person, so you start taking the patient's history. So just like the history 2.0, you smile, you welcome node, and get the patient to sit, where are you from, etc., etc. So those things I'm not going into. So we'll come to the main part. So So tell me what brings you here. Doctor, I had gas since about 2 months. So I went to the doctor near my house and he gave me some gas tablets. I took it for about 1 week, but there was no relief. And I again went back to him and then he said, okay, we'll take an X-ray. And so an X-ray of my stomach was done. And then after that, he gave me a letter to the gastro doctor in the city hospital. So I went there, the gastro doctor saw me and he did a scan of my stomach. And after that, he did a tube test. And after all this test, they told me that I needed a surgery. So I did not have any money at that time. So I went back to my village and, I tried to get hold of some money. I managed to get some money. I sold my cows. And then when I had enough money, I again went back to them, got a date for surgery, and then the surgery was done. And after the surgery was done, then they gave me this letter to come and see. Fairly straightforward. But this does not tell me what the patient knows about his medical condition. They just gives me a story. This story is not enough. So I need to know more. I need to find out the patient's insight. So how do we do that? By digging for more information. So let us do it again. Hello, Mr. Bhargav. How are you? Come have a seat. Tell me, what brings you here? I have had gas since about 2 months, and I went to the local doctor, and he gave me some gas tablets, and I took for about 1 week. There was no relief, and then I again went back to him. Then he took an X-ray of my stomach. After seeing the X-ray, he asked me, gave me a letter. Wait. What was the report? What was the result of that X-ray? What did your doctor tell you? Well, he did not say anything. He just said that I'm giving you a letter to see the gastro doctor in the city hospital. Okay. Did he tell you why he was sending you to the city hospital? Maybe for better treatment? Okay. So then what happened? So the gastro doctor saw me and he asked me to get a scan of my stomach, and then he also did a tube test. And then he said, yes, surgery is. Wait. What was the scan result? What did they tell you? I don't know what the result is. They said something I could not understand. And they said surgery is required. Okay, then what about the tube test? What was the result of that? What did they tell you? What's wrong with you? Well, again, after the tube test, they said that they have, found out something that surgery is required. Again, I am not very clear as to what was that about. They said something, but I did not understand. I'm a poor person, sir. So, okay, fine. Then they said that you need to undergo a surgery. Yes, sir. Then what happened? I did not have any money with me, so I went back to my village and tried to arrange some money. And from here and there, I sold my cow, and finally, I managed to find enough money. And then I got a date for the surgery. And after the surgery was done, they gave me a letter to come to meet you. Okay, so did they tell you about the surgery? What happened? I mean, what was the surgery all about? What did they find? No, I don't know. But after surgery, my gas problem is now gone. But I'm feeling tired. I'm not feeling good at all. I'm always tired. I don't know whether surgery did it. I'm always tired. Okay. So they gave you the letter to come and see me. And did they tell you why they were sending you to see me? I think rest of the treatment will be here. So if you dig, you will get more information. And what is information you have that the patient does not understand most of the things that were done? He understands a few things, but most of the things he has no clue. Now, this is the patient's insight. There are a lot of blank spaces. And this is important for us. This is to be done for every patient. Every history taking, you need to find out what's the patient understand. Because when it comes to communicating the truth, the method is to understand where all the blank spots are. And when you get a chance to communicate the truth, you fill in the blanks. And as you fill in the blanks, gradually you escalate the information. And we will learn how to do that. So before any procedure, you have to prepare. So go through all the medical conditions, just be thorough. You should know about this patient's medical condition. In case the patient has any questions at the later stage, be prepared. And communicating bad news is an elective procedure. Sometimes you may end up doing it as an emergency procedure, but by and large, it is advisable to do it as an elective procedure. What that means is you can keep aside a specific time for yourself where you are unlikely to be disturbed in between. So the dedicated time is the important part. Just like any surgery, if you want to do a cholecystectomy, maybe you may do it in an emergency, but by and large, doing an elective surgery gets better outcome. And then the environment, I always have drinking water, paper cups, tissues, because there might be some tears involved. All of these things will be within reachable distance. And then don't forget active listening. So sometimes the patient may ask you without you wanting to explore. The patient may himself or herself ask, Doctor, what is wrong with me? What is my problem? Please tell me, I want to. But if you have a patient who is not asking, you can explore. Basically, you can poke. Mr. Bharat, you told me you continue to feel tired. Do you wonder why? Do you want to know more about your problems? So this is one way of exploring, just poking the patient to get a reaction. The patient may probably say, yes, I do want to know more. If the patient does not make eye contact, is just, not looking at you and does not respond, most likely the person knows that something is serious. The person may not know the technical words or the details, but the patient knows that there is something serious, and the person may not want to talk about it just now. But by and large, if you explore, the person may respond, yes, I want to know. But that does not mean you can start telling the bad news, because you have to be 100% sure. And for that, we give a warning shot. Mr. Bharat, if it is something serious, would you still want to know? Now, warning shot is for two purposes. One, it suddenly changes the atmosphere. It creates, it makes the atmosphere more serious. Because you need that kind of atmosphere for focusing the energy of both parties in this discussion. Secondly, it gives a chance to the person sitting in front of you, the patient, to reconsider whether whether I need to really note this or not. And the warning shot, you have to frame it properly. You cannot beat around the bush on this. It has two parts. One conveys a message that something might be serious. The second part conveys or asks the question, do you still want to know? In Hindi, I may say, अगर बात कुछ serious है, तो क्या फिर भी आप जानना चाहेंगे? In Malayalam, I may say, കാര്യങ്ങൾ ഇത്തിരി serious ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? In English, I would say, if it is something serious, would you still want to know? So basically, whatever language you are using it, practice how you are going to deliver it before you do it. Practice it, because you can't afford to make a mess of a warning shot. So once you have given a warning shot, focus on the body language of the patient. If the patient is not making eye contact, the person does not want to know. The person may look at you and say something like, can you give me my medicine and I will go and come back after 1 week. So the person is changing the topic. The person does not want. Or the person may tell tell it to my children or tell it to my spouse. The person does not want. Or the person may just say, I don't want to. So basically, any of these verbal or non-verbal, especially the non-verbal, no eye contact, is very, very clear. Do not proceed with communicating bad news. when you see something like this. On the other hand, if you have somebody who looks into your eyes and very clearly says, yes, I want to know, then no confusion. The first part of individualized disclosure model, you differentiate between a person who wants to know and who does not want to know. And the warning shot differentiates that without any confusion, without any doubt. Here is a person sitting in front of you who's looking into your eyes and says, yes, I want to know. Only then proceed. So how do you go about proceeding to tell the truth? You tell it like a story of the patient to the patient from the beginning of the medical condition. And as you tell the story of the patient, the same story that the patient told you, you're telling it back to the patient. But while you're telling it, you are going to fill in the blanks with the knowledge that you have. So the sharing of information is filling in the blanks. And as you fill in the blanks, you gradually escalate the information. Maybe you will, once in a while, you will see that the patient stops eye contact because the patient has found something totally new that the patient did not know. And that might take some time for the patient to digest. And once that is done, once that has gone down, then the patient may again make eye contact with you. Sometimes the patient may not make eye contact for a long time and you don't know what to do. So at that point of time, you can ask, should I proceed? Because when the person is not looking at you, you have stopped, you have paused the storytelling. You have paused till the eye contact is made again so that you can start. But if the pause is very, very long and you are feeling a little uncomfortable, you can break that pause by asking a question. Do you want me to proceed? Or what are you thinking about? Something like that. And after that, the patient again looks into your eyes, then you can continue the story. If despite that, the patient does not look into your eyes, that means the patient had enough. That could be the 62.8% or the 79.9% or the 88.8%. We don't know, but that is the optimum information that the patient had. You tell more information, it may be injurious to the person. So you stop there. If the person persistently shows that does not want to know more, you stop where the patient wants you to stop. You don't have to finish the story. You don't have to tell the 100% of information. You just give as much as the patient wants. And it is all based on your observation of the body language of the patient. So I'm going to just do a small role play of for how we are going to do this, of telling a story. Mr. Bharat, you have been suffering from gas since about 2 months, right? And you went to the local doctor, he gave you some gas medicines you took for about 1 week, if I remember correctly, and you had no relief. So you again went back to him and you told me that he did an X-ray, right? The X-ray showed something like a shadow. And to know more about the shadow, he referred you to the city hospital to meet the gastro doctor. Now look at this. The first fill in the blanks is something like a shadow. In Hindi, like parchai jaisa kuch dikha. In Malayalam, nedala pole endo kantu. In the next sentence, it has been escalated. It is no longer something like a shadow. It is shadow. It has got a promotion. So something like a shadow becomes a shadow. So you are filling in the blanks and you are escalating the information. Oh, I didn't know that. Okay. And in the city hospital, your doctor did a scan. You told me about that. Yeah, the scan showed something like a tumor. That is why, to find out what this tumor was, they asked you to get the tube test done. So here you can see that the eye contact is there. Even though the patient is not saying anything, you can continue with the story. The tube test was done to see if your tumor was something like a cancer. In Hindi, I would say परछाई जैसा कुछ दिखा एक्सरे में, तो ये परछाई क्या है जानने के लिए आपको सिटी हॉस्पिटल में भेजा। वहां पे आपके स्कैन में कुछ गांठ जैसा कुछ दिखा, और ये गांठ क्या है जानने के लिए आपको ट्यूब टेस्ट करवाया गया। ट्यूब टेस्ट करने का मकसद ये था कि देखने के कहीं ये कैंसर जैसा कुछ प्रॉब्लम तो नहीं है। So that is how you would say it. In Malayalam, I would say something like, Nedale pole endo kandu X-ray le, Nedale endaanennu അറിയാൻ വേണ്ടിയായിരുന്നു സിറ്റി ഹോസ്പിറ്റലിൽ വിട്ടത്. അവിടെ സ്കാൻ ചെയ്തതിൽ എന്തോ മുഴ പോലെ എന്തോ കണ്ടു. ഈ മുഴ എന്താണെന്ന് അറിയാൻ വേണ്ടിയാണ് ട്യൂബ് ടെസ്റ്റ് ചെയ്യിപ്പിച്ചത്. ട്യൂബ് ടെസ്റ്റ് ചെയ്യുന്നതിന്റെ ഉദ്ദേശം ഇത് എന്തെങ്കിലും ക്യാൻസർ പോലെ എന്തെങ്കിലും ആണോ എന്നറിയാൻ വേണ്ടി ആണ്. So this is how you gradually fill in the blanks and gradually you escalate the information. Do you mean to say that I have cancer? I'm sorry. Mr. Bharat, do you want me to continue? Do you want to know more? They had operated and removed my cancer, didn't they, doctor? I'm sorry. When they opened up your tummy, they found that the cancer had spread all over. They could not remove it. They lied to me. So now the emotions are coming out. The emotion need not always be tears. It can be stunned silence, the hand on the head, or it can even be in the form of anger. They lied to me. So whether it is tears or stunned silence or anger, please understand emotion is part and parcel of this. And how do you deal with a patient who is emotional? You just shut up, don't do anything, don't say anything, just be there. Now, this is the most difficult part for us doctors, because all through our life we have been taught and we have been doing something. We have never done nothing. It is very difficult to sit there with a person who is sobbing and don't say anything, don't worry, everything will be all right. God is there with you, we are there with you. That's all really stupid, useless statements, cliche statements. The most important thing is, as long as the emotion is flowing, be there with the patient. This may be a good opportunity for a human touch if you're comfortable with it. If you're not comfortable, don't do it. But just a touch, hold it there, take it off. Don't say something, don't do anything, just be there. Something I can think of as an analogy is a surgeon, while during surgery, if there is a bleeder and you can't cauterize it or ligate it, what the surgeon do? Will take up a mop and just put over there and apply pressure and don't do anything. Just wait till the bleeding stops. It is something similar. You just wait till the tears stop. But you have to allow it to come out. If you say something which stops the tears, the patient's emotional state will continue. You have to allow ventilation of emotion so that the emotional part of the brain finally comes down, so that the rational part of the brain rises up, and now we can have a discussion. But till that time, don't say anything, don't do anything, just be there. While people are very, very emotional, they may say something like, doctor, how much time do I have? Doctor, I'm so worried, I'm so scared. So things like that. Now, when people say something, we don't know why they are saying what they are saying. Therefore, do not assume. Remember our previous session? Do not assume. So this is a doctor alert situation. Do not assume. How much time do I have, doctor? Why are you asking that? Why? What made you ask that? My daughter's marriage is fixed, 6 months now. Should I prepone it? You tell me, doctor, what should I do? So here is a patient who wants to plan. That is why this person asked this question, how much time do I have, doctor? Until unless you ask, you will not know. And the same question can be asked by another patient. The same situation, same question, another patient. How much time do I have, doctor? Why do you ask that? Why did you ask this? Why did God do this to me? What did I do to deserve this, etc. So here is a patient who did not ask that question to plan something. Here's a patient who is still in the mode of ventilation, right? So you have 100 people saying the same thing. How much time do I have? And they may have 100 totally different reasons for saying that. So don't assume, ask, and you will get the information. It's as simple as that. So once all the emotion is drained out, it doesn't take much actually. Somebody who's crying, for them to calm down, just take a few, 30 seconds or to a minute or two. That's about it. It seems like ages to us when we're just sitting there. While you're sitting there, don't look at your WhatsApp or Facebook or trying to write the notes while you still have time. Don't do any of that. You have to be 100% focused on the person. Your whole being should be available to the person. Body, mind, soul, everything should be available to the patient at that point of time. That is what you do by not actually doing much. That is what you do. So once the emotion has subsided, now people can talk about what can be done, what cannot be done. So what realistically is possible. Remember last time I had talked about, I often have to tell the patient that, the disease is incurable, it's progressive, but there are a lot of things that we can do to make sure that you are comfortable, and I'll always be there to provide that. So that kind of participatory decision making, giving realistic hope, never giving false hope, all of those things that we learned last time, we can do and finish this. So that is how we manage truth telling. And I know we are just running ahead of time. So we'll go to the next part, which is anger. Now, I want to clarify that we are not talking about law and order situation. We are doctors, medical professionals. We are trained to be medical people. We are trained to manage clinical situation. We are not trained to manage law and order problem. Even if somebody gives you a lathi, you will not know how to break somebody's leg with that. And it's just not possible for people like you and me to even do it. If somebody were to give you a gun, you will not know what to do with it. That is because we are not trained. So what is the law and order problem that we as medical professionals can face? Mob violence. You have 10, 15, 20 people, 30 people coming in a very, very angry mood and trying to destroy everything in their path, the computers, the hospital windows, doors, and you. Then the best course of action is run from that place, run away, because you need to protect your life. This is a law and order problem. You are not an expert on that. Another law and order problem I can think of is when somebody is under the influence of alcohol or substance and totally out of reason, and you can't deal with that problem. So if that person is bent on trying to kill somebody, then the smart thing is not to get killed. Run away from that place, move away from that place, and let people who know how to deal with it, the police, the security, etc., etc., let them deal with it. At least you don't, try to save yourself. Many times, what we can do is to manage an anger situation in our clinic environment. And many times, managing that may prevent a law and order problem from developing. So basically, what is anger? Anger is an emotion. It's a negative emotion, just like sadness, crying. However, unlike sadness, anger consumes a lot of energy. So it's a high energy consuming negative emotion. So the idea is to cut off the energy supply. For that, we need to understand what is the energy supply. There are two forms of energy which can create anger, sustain anger, increase anger. One is confronting. Any form of confronting can give anger, sustain anger, increase anger. For example, arguing. Arguing with an angry person will make the person more angry. If somebody is very, very angry, then even trying to explain will increase the person's anger. If somebody is extremely angry, even trying to apologize will increase that anger. So anything and everything can become a confrontation, just depending on how high the heat is. Another form of fuel, totally different kind of fuel, is ignoring the angry person. If you turn your face away from that person, show your back to this person, maybe you're scared, but if that is what is happening, that person will get very, very angry if you're not responding to this person. So damned if you do, damned if you don't. If you respond, you end up causing more anger. If you don't respond, you end up causing more anger. And another way, another example of confrontation is if your friend or your manager or somebody from your team comes and stands near you, because then the angry person will feel that you are ganging up against him, and that will make the person more angry, because an angry person is also a scared person. So anything that feels like a threat will increase the fear as well as the anger. So therefore, confrontation and ignoring both will increase anger. So we have to do something which is neither. And that is the tricky part. How do you do it? How do you manage somebody without either confronting him in any way, at least talking to him or ignoring him? None of that works. So remember, how do we manage ascites? Right? You have a tummy, a big tummy full of fluids. If you punch the tummy, does that solve the problem? No. If you ignore the tummy, does that solve the problem? No. So what do? We take a needle, attach a line to it, and we put it in the tummy, and the fluid starts coming out in a controlled manner. We are neither confronting via punch, neither are we ignoring. So to be the needle which will draw out the fluid in a controlled manner, you have to use your body language. And what is that body language? Imagine a situation outside your OP, outside your casualty, outside your ICU. You are there and you can hear loud voices and bad words. People, this guy is talking about the deficiency in your genetic material, right? And when you come out, you see this angry face, just like a demonic face, and he's pacing around and loud voice, bad words, everything. Remember, somebody who is very angry, there is so much of adrenaline, that person cannot sit down. It's just not possible. That person will be standing or pacing around. That person just cannot sit down because of so much of adrenaline. Therefore, remember, in our previous session on non-verbal thing, if we are aligning ourselves at eye contact, it is more satisfactory to the person. The same things apply here also. So let us see how we can be the needle which draws out the anger without causing any disturbance, any harm to, first of all, ourselves, to our institution. So focus on the body language. As I said, if you are sitting while the angry person is standing, you are creating a hierarchy, and that will create more anger. So you also stand up, because obviously you can't make the person sit down, because if you tell the person, please sit down, sir, oh, you will make me sit down, huh? So that person will get more angry, because this is not the time to make the person sit down. That person cannot physiologically sit down. There is so much of adrenaline in the body. So you all stand up, because when you stand up, you are making eye contact at level and you are showing equality. That is a good message that your body is sending down. It's a soothing message. It is a positive message. It's a calming message. Then when you stand with a slight kyphosis, not bent too much like the Air India Maharaja of old times, but just stand with a slight kyphosis, because when your body posture is of slight kyphosis, bent forward, you are showing that I am here to listen to you, and that is being respectful. Remember, when we greet somebody, we always bend a little, right? A slight kyphosis. But that slight kyphosis you maintain, because you are showing respect, you are showing, your body is showing that I am here to listen to you. Another positive message you are conveying to this person. Keep your hands where the person can see, because if you hide your hands in your pocket or keep it behind your back, the person can't see. So in our brain, psychologically, we are scared whether the other person is going to harm us. And what is the best way of harming us? Hiding a weapon in our hands. Therefore, all over the world, when people greet in friendship, or at least they are conveying that we don't intend to harm you, there is always a hand gesture involved. For example, hi, namaste, or salute, whichever way. So in all these situations, you show the hand, and that also calms down an angry person, because the angry person, you're telling with your body language without saying a word that I do not intend to harm you. I am not a threat to you. So this is how your body should be. Standing position, slight kyphosis, hands preferably in front where the person can easily see them. Now let's focus on your face. Eye contact. Eye contact shows, one, that I'm engaging with you, plus it shows that I'm confident. It's a very, very positive message. It is not easy to get angry with a confident person, or at least maintain anger with a confident person. It's not easy to be disrespectful to a confident person. So your eye contact gives that message that I see you as my equal. I am standing up. I am willing to listen to you. I'm here to listen to you. And that is the slight kyphosis. I am not a threat to you. My arms are visible to you, but I am confident. I'm confident. I own this place. I'm a master of this. But there should be no arrogance in your face. Just a cool, calm confidence. And there should be no smile, because a smile here will be seen as a threat. And you encourage this person to ventilate more. And how do you encourage? We make eye contact and we nod our head. But here, don't make encouraging sounds, because that may also be seen as if you are making fun of that person, and that may escalate the anger. Don't say, okay, don't do that. Just make eye contact, keep your face serious, and then nod, irrespective of what the person is saying. Because remember, you should be a fool to respond to that person. You are doing this, you are doing this as a standard operating procedure to reduce the person's anger, because we are trying to prevent an explosive situation from actually exploding. And while you are doing this, you will see that the bad words comes down, the volume comes down, the facial expressions comes down, because basically there's like ascites fluid is coming out. Similarly, the emotion, in this case, the anger is getting ventilated, and the person gradually starts coming down. Once the high anger, the high intense heat comes down, now the flame is in simmering mode, right? Now, this is a good time for the first time to open your mouth. And what are you going to say? Ye dil mange more. Merko abhi aur chahiye. So you say, I want to know more about this, sir. Can we sit somewhere and talk about this? You open your mouth and give an invitation to sit somewhere and talk only when you have brought the high anger down. Now remember, this high anger is happening in a public space. This person is shouting and giving all kinds of angry, saying all kinds of bad words. So everybody in that public space is stopped in their track. The patients, the family members, all the hospital employees, everybody is just stopped, and the whole thing comes to a stop. We cannot allow this to happen, because this anger can get infectious. Other people will start getting angry, because everybody is stressed. who has come to the hospital. Everybody is sick. Nobody is well, except, and even we as healthcare professionals are also stressed out. So the anger is infectious. More and more people can start getting angry. Then it can get out of control. Therefore, the minute you get this person's high anger come down, you offer to, can we sit somewhere and take this person immediately to some room where this person has been taken away from the public space. And the moment this person physically is not there, then the public space will come back to normal routine scenario. So it is very important to get this anger calmed down, and then the anger is not gone, but then you take this person to sit and talk. Basically, you say, I want to know more about this, sir. Can we sit down somewhere and talk about this? And then you do that. And then while you are sitting face to face or side to side, you continue the positive body language. But this time, instead of standing, you are sitting. The kyphosis should be still there. The eye contact, serious face, nodding should be there. Basically, you are just the needle which is allowing the fluid to flow, the anger to flow without harming anybody. So this person will continue to tell why this person got angry. The morning there was no electricity, so I got delayed. There was a puncture in my scooter. I got delayed. The security person was not very polite. Then I went to the reception. Nobody bothered to look, and I was waiting for so long. People who had got appointment, who came after me, they were going into a room before my turn came. So the person will tell so many things, because nobody plans to get angry when they get up in the morning. It just happens. The stress builds up. Somebody just blows the top. So you allow this ventilation. Slowly the anger comes down. Your focus is just to diffuse the situation, not to sit in judgment of the character of this person or whether this person was right or wrong. Your idea is just to get the situation under control. If the situation is such that you can offer a solution to the problem, do offer the solution. And if an apology is merited, do give an apology. But don't give an apology just for the sake of it. Give an apology only if it is merited. It should be genuine. It should not be just an apology for the sake of it. So that is how we end this whole situation. I'll give you some examples of how we are going to end it. Thank you for bringing this to our notice. We are very sorry you had to experience this. So here we are saying thank you for this, and we are offering an apology that you had to experience this. Now, another example of how we can do this, if an apology is not needed. Thank you for bringing this to our notice, and this is what we are going to do. I have informed the operations manager on this part, so that something like this doesn't happen again. So if there is no need for an apology, don't give an apology. So to finish the last slide, take home points. Listen to the family when it comes to collusion. Remember, the family also needs palliation of their psychological pain, and that is the starting point of collusion management. When it comes to communicating bad news, remember, you are only a facilitator of information. Your job is not to give 100% of the information, bang it on the patient's head. No, the patient decides whether they want to know or not. And if the patient wants to know, they decide how much they want to know. You just facilitate the sharing of information to the optimum dose that the patient wants. Ventilation of emotion, whether tears or anger. Ventilation of emotion is a therapy. It is not a waste of time, and we have to learn the skill of how to handle emotion. And the way to handle emotion is allowing ventilation of emotion. Sitting there and allowing it to flow, in short. When it comes to anger, non-confrontational, active ventilation of emotion, anger, is an easy skill to master. Of the 3 procedures we learned today, anger management is the easiest. Little difficult is communicating the truth, and the most difficult is convincing the family to abandon collusion. With that, I stop. I'm very sorry I took 15 minutes more, but I just wanted to take time properly to talk about this very important 3 points.
Thank you very much, Dr. Biju Raghavan. See, it's not the matter of time. So much of essential information, especially anger management, is something which all of us know, but we don't know how to manage. So I think nothing overboard. We have got a case presentation which is related to what we have gone through today. Sri Priya, if you're happy to start the share, we'll do the case and then we'll have the discussion together. Hope that will be okay. It's a short case only. I will go ahead with the presentation. Is that right, Sri Priya? I'm going to go ahead
Sure,
as you have
ma'am.
mentioned.
It's your call.
Uh, Hello, everyone. This is the case brought up by one of our candidates, Anna John. And first slide, please. It's a 65-year-old male patient with a diagnosis of carcinoma prostate who has had transurethral resection of prostate with cystolithotripsy, and also suprapubic cystostomy was done. Background history was systemic hypertension. Next slide, please. The main presenting complaints were swelling of both feet for 15 days, decreased urine output also for 15 days, and shortness of breath occasionally in the last 5 days. And he has also had some history of chest pain. Next slide. History of illness. Mr. Hess had presented to OPD with history of swelling of both feet, decreased urine output for 15 days, and shortness of breath, and also for 15 days, and chest pain for the last 5 days. Patient underwent suprapubic cystostomy due to failed urinary catheterization. Then he was planned for surgery to benign prostatic hypertrophy and multiple calculi in the left PUJ junction. But he denied admission in the first visit to the hospital, so went on suprapubic catheter. Later, he came back for review and he underwent TURP and cystolithotripsy. TURP basically is transurethral resection of prostate, and a biopsy was sent. Next slide. Examination. He was oriented to time, place, and no significant pallor icterus was found, and his blood pressure was 157 by 97 millimeters of mercury, temperature 98, and pulse rate was 98, and a saturation of 99%. Cardiovascular respiratory systems were all normal. Abdomen was soft, nothing abnormal detected, just the bladder was palpable. As I mentioned, next one, the basic investigations, hemoglobin, and most of them have been all right. The electrolytes, sodium was 131, potassium 4.7, and the creatinine was 4. Okay, and the creatinine blood urea also have been slightly on the higher side. Next slide. The psychosocial aspects. He was a farmer by profession, landless. He lives with his wife and 2 sons. Both the sons are married. All of them live together in peace. And he has a daughter who is married and stays close by to the house. Daughter is supportive to her family and was there taking care of her father in the hospital. So no psychological issues were there at home. Next one. Medications. He was on amlodipine 5 milligrams for his systemic hypertension, and he was on tablet Urimax 0.4 milligram at night. The main concerns which were, son does not want us to tell his father the diagnosis, fearing that he would not be able to take the news or cope with it. The son did not want the palliative team also to reveal the diagnosis to patient either. Family wants the patient to live in peace and comfort. Family does not want to pursue further treatment because of financial burdens. Next slide. Summary. This case is about a 65-year-old gentleman with carcinoma prostate with hypertension, a supportive and caring family who do not want their father to know what his disease was. So he would be burdened. Main thing, they are very affectionate to him, loving family. So they didn't want him to know. So that was their main concern. So the discussion points. Should we allow family decision and not tell the patient the diagnosis or his diagnosis? Or should we advise them to pursue further evaluation and care? And they've also mentioned what they did. The palliative team explained to the son the need to tell his father about his diagnosis and that the palliative team would be there to answer any queries. And then he agreed to tell his father the diagnosis. Thank you. We'll just go to the discussion, Sri Priya. Ideally, this case is exactly what we had our discussion today with Dr. Biju Raghavan. So we'll leave it open to one and all, either to type in the chat box or unmute and ask. Because exactly, this is really a history where the family are so loving and caring. So we have to follow all what Dr. Raghavan has told us today to take it step by step, do everything what is best for the family, finding the right time to tell it and right way to tell it. Because end of the day, after everything, the same family who were so caring and loving shouldn't feel bad. Oh, if it would have been better off if we would have told him. So that is one thing. And one little thing alone I would like to add on. See what doctor mentioned about collision, like God's grace, I have worked in both East and West. So I have seen patients here who will say, in contrast, as I said, had the opportunity. Here, the only patient will know first. Here, it's something called as patient confidentiality. You are not allowed to tell the family if the patient is not willing to be told. So both things are possible in the world. So it is always better that we are aware of everything so that we have the opportunity to discuss and do. So either you all can unmute and ask, or I'll see what is there in the chat. The patient should have some idea so that he is mentally ready for medication procedure. Yes, that's what. So the spikes. See, even in the previous day when we had the case communication, the spikes or breaking bad news was there. So breaking bad news and collision are something which is very, very essential. That is what something we've got in hand to deal, and communication is what is going to help us to deal. So we have got the problem in hand, and we've also got the way or solution in hand. So we have to combine both to deal with it.
Ma'am, Dr. Triveni here.
Go ahead. Go ahead.
Yes. As regarding the case, that it's true as a daughter, because they're very supportive to the father, and they thought that the father will not able to take it. But we really, the family, maybe they don't know how strong maybe the father or his mental condition. So later, when suddenly he comes to know that he is suffering from cancer or some dreaded disease from some other sources, this is my thought, then can it be possible that it would hurt him more, that the family who is so
Exactly.
supportive?
See, one thing, what I would say, don't assume. What did Dr. Biju Raghavan tell us again and again? Don't assume things. So exactly, it's just learning the skill and implementing the skill. Exactly as you said. No, first thing, we are assuming that he doesn't want to know. It may be the other way around. Oh, I want to know, and I want to help my family to deal with it. I've had such a lovely family. I want to
Yes,
reciprocate
true.
to them. So it could be the other way around. So
Other
they
way.
have done so much for me. I want to share with them. I see many things I want to do, like I don't want to leave any stone left unturned. I want to do something within the time I am alive. So much, such a loving family. So exactly, that is why you have to do a detailed, methodical way of management.
Actually, we have to know the patient mental health, in what stage, whether he would be able to take it or not, or maybe he would be more comfortable that he wants to share his pain with his family. Maybe we don't know really, but I think the clinician.
Either way, it could be true. So that's why not to assume.
Not to assume.
Spend time, and see what you can do. That will be the good way forward.
Yes, thank you, ma'am.
That's it. So we'll anybody else who see both. I would say anyone who wants to ask about the previous like both breaking bad news and collision, whatever, both we could discuss and clarify our queries. We have our expert here regarding communication. That is one of the important skills to be developed, and we have an expert in it. So please utilize it. Any queries you have, do ask him, and he is so willing to help and guide us.
Yes, ma'am. In addition to what other panelists have said, I also think that because it's being CA prostate, which has got a good prognostic, if treated early. So if these such cases, the patient should be told, the family should know that, the treatments are available. So even telling them is very important in this case.
Exactly. Only thing, finding the right time, right situation. It may not be the first time itself. It is just us developing patience and learning the skill. See, many times again and again, I would say, don't imagine that it's going to take longer time. If you learn the skill and technique, follow the spikes protocol, and you understand each step of it, no, you in less time you can convey. And again, one important thing from what in today's discussion, see, we have the responsibility to guide and lead the patient to the right situation to make the decision by themselves. We have to be clear and reveal things. What are the treatment options available? Everything we have to say. And then they may see, if we are not clear, if that patient, that this is also one of my thing. If that person or patient and family is going through and lose so much of money, and for a futile effort, that is also our responsibility. We have not done it properly. So we can't put someone into a financial burden for not leading them properly. See, these are all some own self-conscious effort has to be done. And that is how to take it forward. Collective, multimodal, you have a MDT meeting. So you've got all information before doing anything. So what you have obtained, try to convey and help the patient in a nice way. Help them in all forms, medical, emotional, financial, in all ways. That is why we are here for that. And we are doing it with a multimodal team. And all experts' opinion has been obtained. Try to convey it properly. Dr. Biju Raghavan, go ahead and add on whatever you would like to.
No, I'm just enjoying this conversation that we're having right now.
Okay, thank you.
I think I've
I'm
said
just,
enough.
yeah,
I'm more interested in listening
active
to
listening.
the views of the participants, and I'm really enjoying how you are.
I'm going to read the, thank you very much, sir. I'm just going to read the message in the chat box. In case of any biopsy report which shows CA larynx and the patient is unaccompanied by relatives, but you aren't sure if the patient is ready, what would be the most appropriate things to say when I want to see them for a follow-up with relatives? Okay, go ahead, doctor.
Okay, so if we have a patient and we don't have the family's green signal to talk the truth to the patient, remember, in our country, because we are living here, we have to follow our socio-cultural norms. In our country, the patient's autonomy is not sacred. It is subservient to the family's right over the patient. So family is always above that individual. Therefore, we have to convey whatever information with the patient and talk to the patient only with the concurrence, with the green signal from the family. It is possible that we may get into a pickle because the patient says, tell me what is wrong with me, and we don't have the permission of the family. So we are in the middle of the patient wanting to know and the family wanting us not to tell. In that kind of situation, there is no black and white situation. There are only shades of gray. And here, how I would work in this shades of gray is try to buy more time. Do it all the time, actually. I tell the patient that I need more information and I'll get back to him. Now, am I lying to the patient? Because I know the medical information, and how I would justify it is that, of course, I know the medical information, but that is not the be all and end all of all the information I seek. I also need to know whether the family will agree with me in conveying the medical information to the patient. I don't have that information, whether the family will eventually agree or not. That information is very, very important. So until and unless I don't have full information, the comprehensive information. The medical information was only part of it. So I am not lying to the patient when I say I don't have all the information. The part I don't have is I don't know whether the family will agree with this. And while I buy time with the patient, I will redouble my efforts with the family in trying to manage or break down the walls of collusion. It is not difficult. It is, as I said, is one of the most difficult challenges that we will face in communication procedures of how to manage collusion.
So as I always say, once again, you have to deal as and how it is. As I said, no, why I mentioned my experience was because I have seen both. See, and then one little thing I would like to say, in regard to cancer patient, like the wife was trying to help the husband, but because of her not allowing anybody else to make the decision, we had a case like that. So what happened, the son came to me, and then I said, don't worry then, because the father was in a very terminally ill state, but the wife was scared because she was fearing that he was the only hope for her. So because of that, she was trying to do other modes of management, giving him something else and all, but the family were finding it difficult to manage her. So when they came to me, so as I said, no, always buying time. So I spoke to the son, and then we did a home visit. And then in 2 days' time, the daughter, son, wife, everyone, then they said, doctor, you call and talk. Even though another team went to home visit, then they said,
Yes.
no, you talk to us. So these things do happen. Every case, you have to take it one at a time and deal with the situation. See, if patient is important, you see what is the regional norm. You don't break. And see, sometimes we have to go with the flow. I would like this, will not work. Nothing wrong if it doesn't work. End of the day, we want success for the team, and always put patient's best interest first. Patient is really in a state where he's unable to say anything. But then we did a discussion with everyone, spoke, and after that he was started on morphine. Even morphine he was denied. So this is a practical case, I'm telling. He was given all medication only to cure him. He was in really a very terminal phase, not even able to get up and walk. But only cure methods were given. No other thing was allowed. So these situations can be there. So deal with it one at a time, how it happens, and then take it by time. As I say, always, first appointment, everything to be sorted will not and need not happen. So once you develop that, it will happen successfully, and they will come back. As I said, no, then the whole family came, and I spoke to all of them. Another 1 week or something, he was there on morphine. He was so comfortable. So those things are there. See, as you say, no, cure is not the only thing. We will keep him. See, what is the meaning of pallium? I'm going to basic. That is, you are trying to cure that. No, not cure. You're trying to alleviate the suffering. That is the meaning. So if you stick to that and do, we will be able to succeed. And everyone, see, like a child, we all start. We will succeed, and we will walk, run, do everything. So the belief and confidence only. See, it's such a good thing, opportunity all of you have got to learn it in such a nice way, then practice it and be successful. Anything else is oh, thank you very much. One more thing, something else is there in the chat. Let me read. Thank you so much. Okay. Yes,
Dr.
yes.
Ria
See, that's what they
Masi
meant.
has written something.
That's what I'm
Thank-
reading. Thank you so much, sir and ma'am. I had an experience where the patient himself delayed the diagnosis, seeking other options like homeopathy, which significantly delayed the diagnosis. But it gets very difficult to delay the diagnosis with the pathology report in hand. See, that's what these are things, many things they will go for other forms. I've also seen, I think, a liver disease patient, it was hepatocarcinoma. They went and did some Siddha, I think, and then came back with more severe jaundice. So, but at the same time, no, what they'll say, oh, you're not giving any curative management. I want to try other forms of management. So if you say no, they are upset. So we told, see, anywhere you may not get. So then again, they tried, but they came back when the patient was more sick. So these are situations. See, if you start disagreeing with them, they will literally not agree with you, and it will only be a wrong situation emotionally also for you. So deal with each thing at a time. I do understand what they say. You are delaying the diagnosis. That's what we say. Inevitable. You have to learn to manage and learn this technique. If you learn and talk to them peacefully, anything and everything can be managed successfully. Only it's a learning curve, I would say.
Just wanted to have some clarity
Add
on
on.
that. And no, just wanted to have some clarity. Was it that, Dr. Ria, that you're saying that you had the pathology report in hand, but you could not convey it to the patient or the family? Was that the situation? Because that is not clear to me.
So this is one of the situations one of my relatives faced, and the uncle had gone all alone. So I always think of it as if the patient had not told if the doctor had not told the patient himself and called for a relative at that point, he wouldn't have gone to another homeopathic and other places and could have seen the immediate and the right treatment at time. Because individually, if the patient has already only been told, I feel they feel scared for the family and try to fetch other ways in order to deal with it.
Dr. Ria, why do you think that? So you're saying that the patient was told the diagnosis, was it?
So I'm trying to understand as to whether or not it should be told individually to the patient if suppose it's a CA larynx stage 1, and if you delay it by another 2 months, it becomes like, and it reaches the next stage. But if you're not able to follow up, I don't really understand which place would be the right, like what would you do in order to involve the relatives at what point? Should I say that I'll discuss to you later when they have the report in hand saying squamous cell carcinoma? Because uh, it's but obvious that they'll go and Google out the report and know what it is.
I think when we are communicating, these things like stage 1, 2, 3, or the squamous cell carcinoma, these are for us doctors to discuss among ourselves. What we're telling the patient and the family first in our culture, is that there is cancer, and it is curable, and these are the things that needs to be done. Keep it simple. So, I mean, I just wanted to know whether this patient was told the diagnosis. Did the patient that's the first question, because you're saying that sharing
Yes, sir,
and
the
making the
first
patient aware of the risk. No. Before that is which significantly delayed the diagnosis, but it gets very difficult to delay the diagnosis with the pathology report in hand. So I did not understand that part. So was the patient told about the cancer part?
yes, he was given an idea about what would be the next step, but
And was the family also involved?
no, sir.
Okay, I mean, that is little strange, especially in our culture. It is always the family which first knows. But I'm okay with the patient and family getting to know it together. I think that's the best thing. But telling only the patient is not very common. However, my next point is, the patient has all the right to choose what he or she wants to do. That is what patient autonomy is all about, right? The patient can choose, I don't want to go for any treatment, or I want to go for homeo treatment, or I want to go for, I want to go to the Babaji's ashram. That is the entirely the patient's choice. And as part of autonomy, patients are allowed to make mistakes. If something that they did, it didn't work out and they're in a worse kind of situation, they come back to us, we are still supposed to take care of them. Just because they refused our advice, see, that's what I'm saying. We get frustrated and angry for all sorts of things which are not in our hands. What is in our hands? To get this information and share it with people. That is all that is in our hands. Then it is they who have to decide whether what do they want to do with this information. It is not in our hands. You do your karma and leave it at that. Right? So whether this your uncle, somebody, your relative chose to go for homeopathy is entirely his call. You understand that part, Dr. Ria?
Yes, sir.
So, we cannot put we cannot give, oh, here is the report, you have cancer, then you put a gun on that person's head, you have to follow my advice. You cannot go about like that. None of us can, and we should not. So that's the point.
Exactly. So only thing what I would like to add on is we should not fail to reveal the diagnosis. Okay, if the patient does not want to know, you've got a diagnosis in hand. Either the patient wants to know, you tell, or if he's not in a position, at least bring the family. We should do our duties, and there it stops. And then the decision made by the patient is fine. And as Dr. Biju said, we have to learn to accept any decision made by them. That's autonomy. Only thing, if you have a report and you don't tell the report what it is at all, then it is exactly to what case presentation Dr. Biju Raghavan did today. That patient did not know anything, even though he went from 3 doctors and that is like negligence. If you don't convey what is to be told, that we should never do. We should try to find the best position, situation, convey the diagnosis, decision making, and that also we give them all the choices. Then picking up what choice is their responsibility. They can pick anything. We should be ready to cater to their wishes. We are there to help them and guide them in the right way. Option A, this will give this outcome, probable outcome. Option B, no, I don't want to take A, B, C option. I want to go take D and E option. Fine. So we also have to become open, but we should not fail to reveal the diagnosis. That is what I would say. Add on to what Dr. has had it.
Yes, ma'am. On a lighter note, I was, when sir was presenting the anger, I was connecting with the first case, Bharat. Like he was getting angry at the palliative care physician for, earlier doctors not revealing his diagnosis. So I was trying to, how you can, alleviate such problems. I was connecting with that.
Anger session was very good. See, it's
can
like
get angry for
take
the
home.
doctors not telling him.
It's the best take home for the day, because what you should and what you should not do, so that you to be able to overcome and get out of the situation also nicely. And your example of the ascitic tap, very good. I like that too. Slow and steady, because we as professional, that gives you a very good relation. See, especially when you do ascitic tap, especially in palliative care, we will add on a protein, albumin also will be going sometimes, isn't it? Like, see, because then, so exactly that was a very good example for today.
Thank you.
Okay, Sripriya, I don't, there's no more message in the chat.
Okay.
If everyone is happy.
I have a question.
There's one more.
We've exceeded the time limit. Sometimes
Go ahead quickly.
sometimes we actually come across, patients' family, who are not happy, say they know that the patient might not live long, but they still want to continue everything that can be done. Like, say, if it's a case of chronic kidney disease, they want to still put the patient under hemodialysis or do routine blood tests and things like that. So in such a case, how as a doctor can we convince the family members? Because in India, we do have, family members taking decisions for the patient, especially when it comes to elderly cases, where elders probably might not understand the language or probably do not know what's going on with them. They don't even know what cancer means. So in such cases, how can we convince the family members not to put the patient, through so many interventions, whether it's, weekly blood test or hemodialysis? This is something I would like to know. Thank you if anyone could answer.
I'll first ask Dr. Biju to go ahead and then I will add on.
This is a full session in itself. Just like we had today, one full session, how to deal with, how to counsel patients, and especially family members. In our culture, the family members, how to deal with situations of end of life care, how to answer your question that they still want to continue inappropriate, futile, disease focused intervention, when clearly evidence based medical practice tells you it is not going to help. So that is one thing. Another thing is when the family insists on force feeding the patient, who is now in a state of anorexia cachexia syndrome because of advanced medical condition, not just cancer, many of the other medical conditions leads to that. How do we prevent the terminally ill patient being pushed into critical care and be subjected to CPR and intubation and ventilation? How do we convince the family not to do it? So all three things comes under the session on end of life care counseling. So just today, today I had a family who came to me. Our oncologist sent the family to me for counseling because the patient was beyond any further chemotherapy. And the son of this patient is about to get married in about a month or another month and a half time, and he wants his this parent to be given chemotherapy because he somehow wants, I don't want to give up this option of this thing. So he has been kind of trying to pressurize our medical oncologist to give one more chemo, please. So that way. And medical oncologist was horrified because there's definitely no role for any further chemo. There is no benefit. And then why should you subject the patient to harm with futile medical intervention, inappropriate medical intervention? So I just asked, see, none of this happens very fast. You have to sit there, listen to them, first of all, let them ventilate about their stress and then try to find out what is it that they're looking for. Cutting the story short, I told them that after they understand that the disease is incurable, it is progressive, it is advanced, the person is not, the doctor has said. So I asked them, why do you think the oncologist is saying not to continue his treatment? Why do you think he's saying that? And that was something that made him think. So I said, see, the thing is, no doctor would like to harm their patient. And your doctor is such a nice person, he's such an ethical person that he is thinking of the best interest of your mother, that he's understood that further chemotherapy is not going to save, but it might actually reduce her quantity of life and quality of life. He's trying to protect her from harm by telling you not to go further with my treatment. So he's such a ethical and such an ethical doctor and such a good human being. He's doing it for your mother's sake. And would you want to harm your mother by pushing in these kind of medicine which are no longer going to help? Would you want your mother to suffer? Would you want your mother probably not have as much life as she probably would have if you don't subject her to this? That made him think, right? So, I mean, of course, this conversation was not just shortened to such a thing. I'm just giving you the most concentrated form of what the discussion was about. A lot of non-verbals are involved, your gestures, your expression, everything is involved. But basically, he got convinced. He went back. The oncologist was thankful for this. So things are possible, right? Only thing is somebody needs to teach us. Then if somebody mentors us, great. At least we need to practice it, practice. We get better. Then we end up teaching others.
Thank
Exactly.
you.
One only exactly what Dr. B said. No, I was also thinking, because when you subject more and more of people going through chemo, they can end up in sepsis also. When chemo goes on, it causes depletion of all your white cell counts, and they can go into a severe infection. See, those type of things they may not be aware. Okay, so telling them what are the benefits of chemo and radio, whatever curative, what are the side effects of them. Okay, that is one part which Dr. S explained. And then once again, from your ICU point of view, having worked in ICU for a very long period of time, I'll just give you a quick thing. When you are in ICU, something like that, you can do something called as a 72-hour review, in which you make things clear that the patient has not progressed. You have a goal or marks, like you have vitals or improvement in your infection, something like that. You observe them again and again for 24 or like 2 to 3 days maximum. If there is no sign of improvement, there's only deterioration. So that is something, if someone is not convincing at all. So not that, even though it's a medical decision, we have to convey it to the family, and especially in India, you have to be very careful. Okay, it's not, they'll say, I am the deciding person. Okay, but for me, patient is the best. Always have patient's best interest as first and only. So when you have timed responses like this, you can very clearly tell them this is how it is in spite. And then, like the side effects of chemo and thing, you have so many side effects of being in intensive care. It is not an easy joke being in intensive care. Going through each procedure, each tube going into each orifice is not an easy thing. To NG tube, you all know how much it does. So that you all have to get some, either, as he said, information from others, or gain experience in working other fields. So those are things. So there are very many ways of dealing with it appropriately, getting the right guidance. So get to the intensivist or someone who has enough experience to help us. And again and again, it's a multimodal thing. Because this neutropenic sepsis is something, what I was trying to explain, is a very common thing, which we have dealt with in great detail. Okay, so these are things which they will not be aware of. So we have to explain to them. So everyone may not know everything. So explaining, and then you will gain their confidence. Then they themselves will come, oh, we did not know all this. Oh, then it will turn the other way. Oh, we don't want to harm them. We want to do everything good for them. See, the same person will talk to you like that. So knowledge and awareness does help us a long way. Yes, Shipriya, we have overrun a lot today, but because it's all important thing, no, I didn't want to miss, because we are going to deal with how, like, end of life care. We will see where and how decisions to be made. And with Dr. Raghavan around, I didn't want to miss anything. So sorry, Shipriya, for overrunning, but I think everyone had their queries clarified too.
Thank you.
Thank you once again, Dr. Raghavan, for our enlightening session.
Thank you, sir.
Yes, it's such an interactive one. That is what we want, to make sure that everyone is happy to go and practice.
Thank you,
The
Dr.
positive energy is coming from the participants. That is why
Exactly.
the session is a success.
Like, it's all, everyone together, only it works.
Yes, yes, yes.
Thank you, Dr. Biju Raghavan. Even I was starting in my personal message to my colleague that the communication is going on very lively. We are having a very lively communication apart from the session right now. So thank you everyone for making this as
And
interactive.
very good coordinating by Madam Venkatesh.
Oh, thank you very much. It's just I'm trying to give examples what I've experienced in my practice. That is what is making things. Thank you all. Thanks to God.
So with
So
that,
maybe we are done. Priya?
yes, thank you so much, and thank you everyone for making this interaction lively and interactive. With that positive note, that with a simple note that practice makes things perfect, and urging everyone to start practicing. Those who have not yet started, start practicing good communication skills, making it better day by day. This is Sri Priya, along with Dr. Biju Raghavan and Dr. Ratha Venkateshan, signing off from the Tips Eco Hub. And before signing off, just a gentle reminder that we will not be having sessions on 3rd and 5th owing to Puja holidays. So see you on 7th next Friday with another interesting topic and yet another eminent faculty. Till then, everyone take care. Bye-bye.
Happy Puja holidays to one and all.